Okay, good afternoon, everyone. It's a great pleasure to welcome you all today to the first EAPM webinar dedicated to COVID-19 in perinatal medicine. I'm Elie Saliba, Professor of Pediatrics and Neonatology at the University of Tours in France and President of the EAPM. I will have the pleasure to moderate this symposium with Professor Diogo Ayres-de-Campos, Professor of Obstetric Gynecology in Lisbon, Portugal, and elected President of the EAPM. Before introducing the session, please let me say a few words about our society, EAPM. EAPM, the purpose of our society is to bring together physicians and healthcare in Europe who are interested in promoting perinatal medicine, in particular by disseminating research, knowledge of perinatal medicine, contributing to the improvement of teaching standards in the profession, and proposing guidelines and standards of care. EAPM organizes also the European Congress of Perinatal Medicine, ECPM. This is held every 2 years in a major European city. In 2021, it will be held in Lisbon, Portugal, but I will leave to Diogo the privilege of giving you a few details about this Congress. As for this symposium, we will have 3 presentations with question and answer after each presentation, and a panel of discussion composed of specialists in the fields of obstetrics, neonatology, and epidemiology from countries that unfortunately have been severely affected by the current pandemic. You are welcome to submit your question online during the session, and the speakers will try to answer all your questions as much as possible. Otherwise, we will send you the answers by email. And also, I would like to remind you that the symposium will be recorded, and the recording will be available on our EAPM website. We will end this session with a general discussion with the 3 members of the panel of discussants, who will, of course, be able to intervene at any time during the different discussions and answer questions from the participants. So, Diogo, I'll give you the floor.
Thank you very much, Elie, and a very warm welcome to everybody to this, indeed, the first webinar we have hosted within the European Association of Perinatal Medicine. So I'm very happy to be here with you in this webinar. On one hand, on the other hand, somewhat sad because it should have been this week that we were housing here in Lisbon the 27th European Congress of Perinatal Medicine, which had to be postponed. It will now be next year on the 14th to the 17th of July 2021, also in Lisbon. But in the meanwhile, we thought it would be good to share some of the experiences that we knew were being accumulated in several parts of the world, and particularly in Europe, regarding COVID-19 and its influence on perinatal medicine. So very happy to be here with this group of people who have been dedicating a lot of their time to the COVID-19 pandemic and its influence on perinatal medicine. So I'm going to go to our first speaker, who is Professor David Baud. David Baud is the chair of the Department of Obstetrics at the University Hospital in Lausanne, Switzerland. He has a special interest in infectious diseases in pregnancy, has published a lot on this issue, and he's one of the founders of the COVID-Preg International Registry, together with Dr. Guillaume Favre, who is with him. And so I give you the floor, David.
Share screen. So share screen. Can you see now the presentation?
Yes.
Perfect. So I would like to thank the organizer to invite us to present COVID-Preg. As we said, I am one of the founders of COVID-Preg, but the hand and the brain of COVID-Preg behind all the work we have done is Guillaume Favre. Guillaume Favre is a resident in our institution, and he's dedicating his night and weekend to run COVID-Preg, and since he invests a lot of work in it, I thought it was a good idea that he present his own work, and I will make some conclusion at the end and present briefly some results we had with COVID-Preg. Guillaume.
Hello everybody, and thank you David for introducing me. So we're going to talk about the COVID-Preg registry, which is an international registry based on COVID-19 and pregnancy. So as you know, we are still interrogating about the real impact of SARS-CoV-2 on pregnancies, mainly because we lack strength data about maternofetal and neonatal outcome. So next, yeah. So just to remind everybody that we have experience on that type of study, especially on internet and online platform with first the DICA registry in pregnancy, which was made in 2016, and it was based on the same basic platform that we use now for COVID-Preg. And also maybe you know the phenotype.com's website, which include a lot of information for fetal medicine. About our international registry, in this emergency pandemic context, we have created an international network first, now counting more than 240 co-members in more than 160 hospitals from 23 countries around the world. So the concept of COVID-Preg is based on data sharing between centers in order to have as much data as possible, allowing us to understand the impact of the COVID-19 on pregnant women. But before doing this, we needed to think about the architecture of the project before simply go ahead. Regarding the quality of data, we needed to harmonize data collection. Because we work with a lot of institutions worldwide, we needed a very ergonomic and easy solution to collect information. And we all know that gathering data can be very tricky and time-consuming, especially in the emergency context. Then we made a dynamic survey asking relevant questions to related specific situation of your patient, that facilitating the collection process. So with this information, we developed a plug-and-play online solution allowing partners to collect data easily, sharing valuable information about COVID-19 and also allowing every centers to have access to their own data and free to use it and to analyze it. Note that only the COVID-Preg team here in Lausanne have access to all the data, and every center can have access to their own data. Of course, ethical committee was approved in many countries, such as, of course, Switzerland, in Ireland, in France, in Spain, in Brazil, in Canada, and a lot of others. For this project, to gather the maximum partners we recently published an article in the Lancet entitled An International Registry for Emergent Pathogen and Pregnancy, explaining our goal to build that strength network for this crisis, but also for future crises. So the inclusion criteria for our COVID-Preg registry include every pregnant woman suspected of SARS-CoV-2 infection. In order to assess natural clinical history of SARS-CoV-2 in pregnancies, to identify maternal, fetal and neonatal risks, and to estimate risk factors and prevent the maximum adverse outcome. Every data we need are basic data we can get on standard obstetrical medical records. For example, I will show you a bit the registry, the platform we use, the RedCap platform. Note that it's a very basic graphism, but it's very ergonomic and easy to use. If you see the main menu of the registry, so you can see that there is a menu here and the question on the right. When you start adding record, you see the two columns here corresponding to the two periods of collection data. So the enrollment period first and then the follow-up periods, and you have the forms related to every period. So you have the natural history form, the pregnancy outcome, neonatal outcome, and second infant outcome if it's a twin for the survey. So let's see, when I say this is a dynamic survey, let's see an example of, you don't need to read and answer every question. You just answer specific question related to your specific situation. For example, here we have the form for the ultrasound during the pregnancy. So here, the first question is, did the patient have a first trimester ultrasound? If you click on yes, you will be the question corresponding to your first answer, and then you will have to fulfill all questions. But if you don't have any information about the first trimester ultrasound, you get back to the first main page. You don't have this question. So it's just based on a practical aspect to make the user very friendly with the survey and easy to use. Another example, when you have to click on the pregnancy outcome, if you click on the live birth outcome, we're gonna have an error system, because you need also to tip the gestational age at delivery. And if it's not corresponding to your first answer, a live birth 15 weeks not possible, you have an error system commands that allow us to have a quality on our data. We built the forms on a friendly user aspect, also with the different professionals that can collect information. Because we know that we work together with neonatologists and gynecologists, so every form can be fulfilled independently of each other. For example, for the neonatal form, you have here again the same question as the pregnancy outcome form, when you have to tip the pregnancy outcome. This is the only question that is repeated, and it's a very small question to allow different professionals to fulfill different forms. For example, if I'm working with the neonate and with the neonatal team, and he wants to help me to fulfill the form, I can just fulfill my obstetrical form, and he can do his own form in his side. So it just collects the same information here, and it's also another quality system, because you can have two different answers to that question. So here you have an example of newborn question. For facilitating the data collection, we made two tutorial videos that can be available on YouTube and very easy to watch. It's just 1 minute video that can explain everything on the registry for you. Just to briefly present the team, so the project is leading by Professor Baud beside me, and Professor Alice Panchaud, whom I have the great pleasure to work with by coordinating this registry. And you see my other teammate working hard with me on that project too.
I will just come to very shortly to some data. We are currently doing our first interim analysis. So far we have a little bit below 1,000 patients included. We have 600 patients with full data, which means they have delivered. They had COVID-19 at some point. Some of them had before delivery. Some of them had at the time of the delivery. And we have at the moment a little bit more than 200 pregnancies that are still ongoing, where we don't have the full data because we wait for the delivery. This is just an example of analysis we are doing very often to see where we go. This was an analysis that we did 2 months ago. We had at that time, when we were a little bit below 100 cases in the registry, we had 4 very severe cases. At admission, we have 78 cases with mild to moderate symptoms at admission. You see that about half of them were delivered vaginally. Some of them were delivered by cesarean section because of obstetrical reason, and some of them were delivered because the team decided to deliver by cesarean section because they were COVID-19. You see that after delivery, some of them progressed to severe symptoms, and some of them remained with mild to moderate symptoms. We have published several papers on COVID-19 and pregnancy. Tonight you will see another paper in the JAMA that should be online, as I said, tonight. And our Zika experience also allows us to publish several papers in some very good impact factors journal. I will conclude with a paper we published in The Lancet describing the registry. The last sentence of this paper was, any healthcare provider supporting the registry by providing well-documented cases will be considered as co-collaborator of the registry in any future scientific publication. And I invite you to join us and to go on covidpreg.ch to join us and to bring some more cases to be able to make a good analysis. Thank you very much.
Thank you very much, David and Guillaume. May I just ask all the participants if they have any questions to David and to Guillaume, if they can write it in the question and answer box just below, and I will transmit them to our speakers. And also, if any of our panel members want to intervene and ask, please go ahead. I have just one question, David, which is that, as I'm sure you're aware, with 629 patients, it's by far the largest data set that we have available at this point. Even if we count for those who haven't been published, but we know that they have been accepted and will be published very soon. So when do you think is the time that you should actually come out with the first analysis of the data?
We were waiting for 1,000, but I think we start this week to analyze all the data. I think we will first do a paper on the maternal outcome, which was thought to be as the general population. But from what we quickly see from a very quick analysis, about around 10% of pregnant patients will end up in ICU, which is, I think, much higher than what we expected. So we need to continue this analysis, and we expect to submit a paper by the end of June.
Okay.
David, can I ask a couple of questions? First, I think you had fantastic track record with the Zika registry, and I just wondered, what lessons have you learned from Zika registry that you have applied to COVID, and is it exactly the same, or have you is this an improved version? And also, I'm interested in what specific research questions will you tackle through this registry? Because just listening to you now, it's going to be very difficult to interpret this data without proper control group. Just specifically, for example, on the issue of admission to intensive care, in many countries that means different things to different people, and it is entirely possible that people have been admitting pregnant women to intensive care unit just because they have COVID, not because they were sick. So I just wondered how are you going to put it all together in a high-powered scientific paper?
It is always, we have to answer one question per paper. and not try to mix everything and to present everything in one. So it will be probably different stories. I'm quite really worried that we always say that pregnant women have a similar risk as the general population. My impression is yes, there is a similar risk as the general population of patients of 60 years old, which is not the same as 30 years old. I think when you compare two patients with the same age, my feeling is that pregnancy could be a risk factor. So this is probably one of the first questions I would like to answer. The second question is, I'm really interested in congenital infection. So far, it seems that the risk of vertical transmission is very low. We have one case of placenta infected by SARS-CoV-2. So far, there is no cases described with transmission to the fetus, but this is another question that interests me also a lot. So there will be one question per paper. Now, which one will we start first? I think, on my point of view, we should start with the maternal disease first.
May I ask a question? May I ask a question, please?
Yes.
Enrico, can I just give me a second, because we don't have a lot of time, but I'll come back to you in a while. We just have a couple of questions that I think you could answer quite quickly, David, from the audience. Didn't want to, it's been here for some while. One of the questions is, how do you control for overlapping or duplicate reporting?
So this is really difficult. It will be quite easy to see if you have exactly the same data duplicated. So this will be quite easy to check for that. Now, if these data have been used in another registry, we will not be able to control for that. I just come back to the control. Our point of entry is suspected cases of COVID-19. Some of the cases that have been entered have been tested negative then by PCR, and this will be our control group.
Okay. One of the questions is, how many of the 629 are tested positive for COVID-19 in the database?
2/3 at the moment.
2/3. Okay. Enrico.
Okay, thank you. Thank you for great work. In our experience, we found that among the 250 cases we recorded in Lombardy, obesity was a cofactor, a significant risk factor for severe cases. So obesity is not just obviously being heavy, it means suffering of chronic low-grade inflammation. And so we found that the pre-pregnancy BMI was significantly related to severity of COVID-19. So, and that is collinear with macroethnicity for, at least in our country, first-generation immigrants from South America, from Northern Africa, from Egypt and Syria. They often live in poor socio-economical condition, poor housing, and so poor food. So obesity is collinear with macroethnicity. So, and I think this could be investigated, because I agree that pregnancy, especially the third trimester, because in the first trimester the prevalence of COVID positive with severe symptoms is negligible, but in the third trimester is obviously the risk factor for the pneumonia complications, so, and coagulation complications. So I think that this comorbidity, and obesity is indeed a comorbidity in pregnancy, should be probably interesting to look for in your fantastic large database.
We have a question about the BMI at beginning of the pregnancy, at the end of the pregnancy. So we will be able to investigate that.
Mm-hmm. Thank you.
There's a question on at what point is neonatal outcome collected? And there's concern about late manifestations of illness after discharge from hospitalization.
Yeah, so at the moment, the form allowed to collect the direct neonatal outcome and up to the first few days after the delivery. We are now adding more forms to check the I would say the longer term, up to 28 days post delivery, and also some other forms for neurodevelopmental outcome up to 2 years. But this is forms that we are building at the moment.
Okay, and there's a question from Hanne Brix Vestergaard from the Danish Society. Do you register different approaches to lockdown, etc., for pregnant women so that data can be compared?
Not. This is a very good question, but we will be able. We will know from which country the case has been entered, and we will be able to investigate that. But I would say the registry is not dedicated to look for this question. But there is some countries who have joined as a whole country, for example, Spain. And for example, they will be able to analyze their own data. So COVID-Preg can be used as a tool, and we will be able to investigate the lockdown method according to the country by comparing different countries. But there is so many factors that might enter into that might be how to say, there is so many factors that can induce infection or not, and so that it will be difficult to investigate this simple question.
Okay, we have a couple more questions, but we don't really have a lot of time, and we can come back to this in the panel discussion. Just one quick question I think would be easy for you to answer. Do you have fetal growth restriction as an outcome in investigation?
Yeah, the partner will be able to enter the weight. It will be the gestational age will also allow to check if it's IUGR or not. So yes, there is this question.
Okay. Well, thank you very much, David, and thank you very much, Guillaume, for that wonderful presentation. And over to Elie for our second speaker.
Okay, thank you, Diogo. Any comments from the panel group? Adelina or no? Okay, so we have to move to the second presentation. Pan-COVID registry and outcome of mild illness or asymptomatic infection, presented by Professor Cristoph Lees and David Edward Mullen. Professor Cristoph Lees is Professor of Obstetrics at Imperial College London. He's a consultant in obstetrics and head of fetal medicine at Imperial College Healthcare NHS Trust. He's internationally recognized expert in fetal growth restriction, invasive prenatal diagnosis, and management of high-risk obstetrics. He was chief investigator of the Truffle study and a co-founder of the International Working Group of Maternal Hemodynamics. He published several important scientific papers in his domains of expertise and had authored many textbooks on fetal growth restriction, maternal hemodynamics, and the widely read Dewhurst textbook of obstetrics and gynecology. Please, Dr. Lees, come up.
Thank you very much indeed for that introduction. I didn't write that, did I? It's possibly the longest introduction I've heard. Thank you. Now, let's talk about another registry, Pan-COVID, which is a UK endeavor. I'm going to present the first few slides to just introduce the study, and Ed Mullins, who is the brains behind this, registry, will talk a little bit about some of our data. So how did we start? Well, back on a skiing trip in February, Ed phoned me and said that we've got to apply for NIHR funds. The National Institute of Health Research in the UK were very keen to fund prospective studies. So we were fortunately successful in that. And have about £250,000 to set up this study, which sounds a lot, but it really isn't that much. We were adopted by the UK's Urgent Public Health group, which meant we were prioritised as a study by all UK hospitals, which is an enormous help because it means that research midwives and research nurses will automatically enter data for us. We have only been open for about 4 weeks, so just over 4 weeks we've been recruiting. So we have some preliminary data, which we'll share with you later. We have a number of co-investigators and project partners, but some of them here, we're quite international. We have co-investigators in China, Brazil, Hong Kong, many European countries, Middle East, and Africa as well. We're doing this in conjunction with the Centre for Trials Research in Cardiff, with whom we've worked on a number of projects. So I just want to thank Julia Townsend and Rebecca Pale and the rest of the team at Cardiff, who've done a fantastic job in getting us up and running within a few weeks in our online database and website. So what's our objective? Well, our objective is to establish a UK and international disease registry. And this is not just for women with COVID-19, but also SARS-CoV-2 infection. And there is a little bit of overlap between this study in the UK and Marian Knight's UCOS, but a minimal amount of overlap, and I'll talk about that in a moment. We're particularly talking about out-of-hospital infection and out-of-hospital diagnosis. We've got 4 specific research questions. We want to understand the effect of the virus on miscarriage, on fetal growth restriction and stillbirth, which is associated with FGR, preterm birth, suspected or confirmed vertical transmission to the neonate, and perinatal infection. So I don't want to blind you with a huge table, but you can't move at the moment for studies on COVID. The good thing is that many of them are different. They're different geographically, different in the way they're looking at things. Some are patient type questionnaires, others are health professional entered data. Most of the data is online. Some are particularly neonatal and pediatric. Some are perinatal, rather like COVID-Preg and pan-COVID, which is very similar in many of the questions it asks. Others require blood samples as well. I think that's a good thing. Every country, every geographical region has the ability, hopefully, to take part in a study. I think the key thing is to establish areas of similarity between the different studies and eventually be able to pool data, whether it's a meta-analysis or something slightly more refined than that. So pan-COVID, 42 countries. We do need verbal consent. We're looking at SARS-CoV-2, COVID-19, early pregnancy loss, growth restrictions, stillbirth, delivery outcome, birth condition. We're very widespread worldwide. Only a few of our non-UK countries are recruiting at the moment because we need local authorizations and local consents from these centres, but we're waiting over the next 2 to 3 weeks. We anticipate that the majority of these centres in different countries will come online. How have we done? Well, we've been open for just 4 weeks. We're recruiting at the rate of roughly 250 patients a week, which we think is quite good. Most of that is UK recruitment at the moment before our international centres come online. So just this morning, Ed told me we had recruited just over 1,000 to coincide with this seminar. So I'm delighted to be able to report that. But numbers really aren't everything. And I think there is a fixation with all of us on numbers, but there are more important metrics in many ways. Now, what are the principles of our study? Verbal consent, so you don't need written consent, and that's our UK ethics approval. We require local approval to be sent to us from any centre outside the UK. We've gone for a minimal data set, so we want to collect only absolutely what is required to test and test our hypotheses and form our conclusions. It's an online data entry. As I say, we keep it as simple as possible, and we've said we'll produce regular reports once more than 1,000 patients entered. So we're working on our first report just at the moment. The study is sponsored by Imperial College. We have support from the International Society of Ultrasound in Obs and Gynae, and also from FIGO, working very closely with Centre for Trials Research, as I've said, and the National Institutes for Health Research sponsor us. So that is really all I want to say, and I'm going to hand over to Ed now to talk about some of our very preliminary data. Before I do hand over, I just want to say that, of course, it's very interesting to consider publishing. It's very difficult to decide when to publish and what number to publish at. We have taken the view that we will publish when we feel that we are adequately powered to answer some of the questions that we pose. So wouldn't expect to see any publications from us immediately, but we will be posting all our a basic template of our results on the website. Over to you, Ed.
Oh, thanks very much, Cristoph, and thanks very much for the invitation to speak to you all today. Can you see my presentation?
We can.
Yeah. Thank you very much. Okay, lovely. Okay, so just to give you some preliminary results.
Sorry, Ed, we can't see it. Yeah.
All right, okay. Is it back?
No.
You have to share your screen.
No, okay, come in.
Yeah,
Are we okay?
That's it.
Lovely. All right, okay. So thanks very much for the invitation. To date, we've got 142 sites, 359 healthcare professionals contributing to the registry, and as of now, just over 1,000 participants have been logged. I'd like to give you just some very preliminary data that we've got from a download last week. We haven't done an interim analysis thus far, so it's just very rough data, but just to give you an idea of the sorts of things that we are collecting. So of the women that we have logged on the registry, about 45% have got suspected suspected COVID-19, and of these, about 60 have tested negative, 280 have tested positive for SARS-CoV-2. The gestation at which we're recruiting women is largely between 23 and 36 weeks, but we've got some coverage from under 23 weeks, and we're really very interested in early pregnancy outcomes, which are quite difficult to capture. And then, as you can see there, just over a third at over 37 weeks as well. We're using the international Delphi criteria for diagnosis of fetal growth restriction. And in those, we see around 2% of the women participating. The centres have decided that they've got fetal growth restriction by those criteria. Outcomes at delivery are very small numbers of pregnancy losses. And most of the women that have been recorded and have delivered have had live births. Gestation at delivery, about 13% of women that we've recorded have delivered preterm. And of course, we've still got a lot of women with ongoing pregnancy as well. Neonatal infection, because the majority of our data come from the UK, we've found that actually the testing rates for neonates are remarkably low. And so of those babies that have been tested, which is only 37, 3 have tested positively. And so this is probably far too early to make any comments on that. And I think the UCOS data is probably more reliable for that stage. In terms of where we're going to take this, we collect a National Health Identifier, which is the NHS number, and we'll use that to get linkage to routine neonatal data from the UK National Neonatal Research Database, and to routinely collected NHS data from the National Maternity Dataset. And NHS Digital will facilitate that common dataset for all of the studies that have urgent public health priority. We've also started to work with FIGO, who we hope will act as an umbrella to pool registry data from worldwide, and other registries such as FOGSI in India and EAPM have provided sort of provisional consent to pool aggregate data at a later stage. So in conclusion, we will be undertaking interim analysis by women who have either suspected COVID-19 or confirmed SARS-CoV-2 infection. From this very, very rough data, pregnancy loss, fetal growth restriction and preterm delivery do not appear substantially increased, which is in line with other data. And we'd of course wait to comment on vertical transmission and note the very low neonatal testing rate in the UK. We'll be focusing on early pregnancy units as they reopen in the UK, and hoping to capture some useful data which will help us to counsel women better with outcomes from pregnancies that have been affected in the first trimester. And we'd acknowledge the limitations of registry studies with case ascertainment. And we look forward to future collaborations with those here and worldwide. And please do join up if you think this would be a good study to take part in. Thanks very much.
Okay, thank you.
May I have a question?
Yes.
Yes, Adelina Pellicer from Madrid. I have several questions regarding the management of neonates. The first question is if you contract for the rooming in or separation between mothers and infants in any kind of your questionnaires. This is the first question. And when is the time the samples taken in the neonate? I mean, I guess you contract for that also in your registries.
Yeah, so for this study, we asked whether the neonate and the mother were separated until discharge from hospital. And we also record any neonatal samples taken, and we leave that fairly open for the centre who's registered the participant. But we have several options to enter different samples taken from the neonate, the centre, and any other samples they might have taken.
Okay, thank you.
We have one question from the participants. How do you avoid compounding factors for IUDR in the data?
Yeah, so we ask the basic demographic questions such as smoking status, pre-existing chronic hypertension, and look at other maternal comorbidities. We're also going to analyse the gestation-adjusted birth weight. And as I say, we use the sort of Delphi criteria for fetal growth restriction diagnosis, acknowledging that we can't collect detailed ultrasound data and remain viable as a minimally burdensome data set.
Could I, reacting to your results or your preliminary results on preterm birth, and we have Marian Knight with us. If I remember correctly, reading the UCAST data, there is quite a lot of preterm birth. I think most of it is iatrogenic. Is that right, Marian?
Yes, that's right. So, and I think it's important to consider the difference between the data that Ed's presented, which is largely women with suspected infection or mild infection who are not admitted to hospital. So in the UCAST cohort, it is only women who are admitted to hospital who are either test positive for SARS-CoV or have COVID-19. And of those, we had 400 women, it's just been published in the BMJ today, 427 women, of whom 60% had given birth, and a quarter of those babies were preterm. But only 19 of the babies were less than 32 weeks. But you're absolutely right, most of those were iatrogenic, most for maternal indications of the iatrogenic preterm births.
And many of them because of COVID-19 complications.
Yeah.
Right?
Yes, exactly. Yeah.
One question here: do they look for cord blood antibodies, Cristoph and Edward?
No.
No.
Okay. I don't have a. Oh yeah. Did you get any placenta infection or vertical transmission?
I presented the data that we have. We haven't yet disaggregated that very small number into whether it was early, say under 12 hours after delivery, or late. So I wouldn't like to comment.
Okay.
Can I make a comment there? Of course, it's extremely, I think it's best to call any infection of the neonate perinatal infection, because it could be vertical transmission, it could be environmental, and it could be from the mother. So it's and with the uncertainty of how good the tests are, particularly in neonates, we can't, I don't think we can make inferences in respect to vertical transmission at the moment, at least.
Can I ask you a question? Did you look for pro-inflammatory cytokines in the cord blood or in the baby?
Did we? No. This is a registry study. We're not collecting blood. No.
Okay. Adelina or other neonatologists, do you want to comment on the pro-inflammatory cytokines in the neonates? Because
no,
can induce brain lesions.
No, we are looking at in a study. We are conducting a study now on breast milk, and we are looking at the transmission, but also all kind of inflammation parameters and so on, because we're really interested on that. Also in the changes that eventually the virus induces in the microbiome. So I probably will try to correlate the number of the viral load against all these parameters in breast milk. So we'll see, because I think this needs further investigation.
Elie, I think we need to move on.
Yes, go on, please.
Yeah, but unfortunately, Zarko has left us. Well, at least I can't see him.
Have I?
Oh, you're there. Sorry. Okay.
He's still here.
You're still here. Great. So, over to Professor Zarko Alfirevic, who is the head of Department of Women and Children's Health at the Liverpool Women's Hospital, University of Liverpool. And he's also one of the coordinating editors of the Cochrane Pregnancy and Childbirth team. Zarko, please.
Yes, welcome. Well, I was going to welcome you to my study room. Actually, I also wanted to introduce my co-presenter today, Declan Devane, Professor of Midwifery, a good friend of mine from Galway, Ireland, who is also director of Irish Cochrane Centre and a member of editorial board of the Cochrane Pregnancy and Childbirth. He will present you our data of our review of national clinical practice guidelines, and I just want to give you the rationale for this work. Like many of you and many institutions, our Cochrane Pregnancy and Childbirth has been under quite a lot of pressure, both internally and externally, to produce something, because anybody who was in clinical academia, you know, if they were any good, they should have said something on COVID. Otherwise, you know, kind of what's the point? And Cochrane, our pregnancy and childbirth group, kind of pride itself on a trusted evidence and a proper critical appraisal of the data, and we really resisted doing anything in the COVID arena because we felt that there's going to be a lot of problems with primary data, that there is going to be a lot of publication of interesting outcomes and no publications of kind of boring outcomes, and therefore the proper critical appraisal is going to be very difficult. There's going to be duplicate records, and we thought that we would prefer to wait. We simply didn't feel that we have a skill and expertise to say something really, really trustworthy on the COVID in real time. However, then we sort of changed my mind and felt that one area where we could produce some sort of reasonable summary would be national guidelines. And so this is the kind of logic behind this work. And I will now hand over to Declan to explain what we did and what we found. Declan, over to you.
Thank you, Zarko. I hope you can see my slides.
Yes, we can.
Great, thank you. So Zarko's given a nice introduction to the context of this piece of work, and previous speakers have indicated that the initial small case series of evidence that was available is now starting to increase. And the COVID-19 outbreak has been particularly stressful for pregnant women and their families. And some of that was driven, I think, by some of the concerns around comparisons with previous corona infections, which weren't reassuring, as you know, and a concern that maybe SARS-CoV-2 would be similarly associated with adverse pregnancy outcomes. And in that context, pregnant women and their newborns, by virtue of being pregnant, were considered as high-risk groups across many jurisdictions, including, for example, the UK and in some regions in Ireland and in other countries. As improved evidence continues to emerge, that's going to be reassuring. That's going to provide better evidence to inform clinical practice guidelines. But currently, accessing and synthesizing that volume of evidence, as you all know, can be quite challenging. Some of the previous initiatives spoken about earlier on in this webinar will help a lot in toward bring that body of information together. So as clinicians and women and their families, given all of these challenges in interpreting and locating critically appraising individual studies, most clinicians, pregnant women and their families are turning to national clinical practice guidelines. And what we wanted to do was to review the available clinical practice guidelines that summarize evidence and provide recommendations for the care of pregnant women and their babies during the COVID-19 pandemic. We did this by identifying and summarizing international clinical practice guideline recommendations for 14 prioritized clinical questions related to the care of pregnant women and their babies. We reviewed the country-specific clinical practice recommendations from all 19 countries that had more than 10,000 reported cases of COVID-19 on the 10th of April this year. We did so because we assumed that countries with that volume of reported COVID-19 cases would have experience and likely have pregnancy-related guidelines because of that relatively high incidence. 2 reviewers from each country who are very, very grateful to and who are named in this presentation shortly on, excuse me, on behalf of the COVID Cochrane Group. They searched for and extracted data independently relating to each of the 14 questions from guidelines that were available in their countries related to the care of pregnant women and their neonates. And we assessed the level of consensus across the recommendations against the 14 questions. A couple of important points to make is we excluded countries where no guideline was available at all, or where the specific question was not addressed in the guideline, to give a more realistic denominator to the level of consensus within the recommendations. And we define consensus as being reached if 80% of the countries with the guideline that addressed the question made the same recommendations. So these were our 14 questions. So they addressed factors through antenatal, through interpartum, postnatal, and so neonatal questions. And they're on your screen there, but they address things like, for example, are antenatal steroids or fetal lung maturation contraindicated? Is it recommended that pregnant women wear masks during routine hospital appointments? Is vaginal birth contraindicated? Use of Internox during labour? Partners being present during labour? Delayed umbilical cord clamping? Skin-to-skin contact, is that contraindicated or not? About separation of the mothers from their babies, and is breastfeeding contraindicated? And these, I'm sure many of you will know, were questions that pregnant women were asking and clinicians were being asked to answer. So we tried to look and see what extent there were consensus across those questions, across the countries with a relatively high COVID incidence. We assessed each of those questions against the following answers. So yes, the guideline recommends the practice. The guideline says consider. No, the guideline advises against the practice. The guideline states that further research is needed, or there is insufficient evidence to recommend one way or the other. The guideline recommendation is unclear. The guidelines within a country are contradictory. That may occur, for example, where 2 professional bodies in a single country produced COVID-related guidelines for pregnancy, and where those may have given contradictory recommendations, which, as you can imagine, will be a challenge. And the final category that we could assign or judge a recommendation against was that the guideline didn't mention the question at all, or there was no guideline available that addressed that question. So we had quite a good geographical spread of countries included, with more than 10,000 cases on the 10th of April, as mentioned. The countries are listed here. So they were Austria, Belgium, Brazil, Canada, China, France, Germany, Iran, Israel, Italy, Netherlands, Portugal, Russia, South Korea, Spain, Switzerland, Turkey, the UK, and the US. And we're very grateful to our broader team of reviewers who extracted the data independently within each of those countries. So we've gone through the analysis already. So what did we find? So this slide perhaps sums up the main findings, and we will show a table shortly. But we had divided our women into 4 groups. They were pregnant women who were COVID positive, pregnant women who were symptomatic, but the COVID status was unknown, pregnant women who are asymptomatic and the status unknown and are at risk, and pregnant women who are asymptomatic and not at risk due to close contact with a known COVID-19 positive person. We then looked at those questions and saw to what extent is there similarity or consensus across the guidelines. And you can see here that across all 4 groups there was consensus that a surgical mask should be worn during hospital appointments. Vaginal birth was not contraindicated in 3 groups of women. Excuse me. And epidural analgesia was not contraindicated in 3 groups of women also. This table here might summarize the information better. It's very small, and apologies for that. I'm just trying to zoom in here if I may. Excuse me, just 1 second. Just bear with me a second. So it gives a graphical overview of the 14 questions down the first column here on the left. And it shows the 4 groups of women then in the columns, and 2 questions related to all women. So for example, the first question is it recommended that pregnant women wear a surgical mask? Yes, it is recommended during hospital appointments. It is recommended across all 4 groups of women. Our additional ultrasound scans indicated there was no consensus achieved there. Our antenatal corticosteroids for fetal lung maturation contraindicated. We didn't find consensus across the guidelines. Consensus again, meaning more than 80% of guidelines recommending the same thing. Is it recommended to undertake urgent delivery where maternal respiratory support is required? That question we asked for all women, and there was no consensus across the guidelines. Vaginal birth contraindicated. It wasn't contraindicated in the 3 groups of women for whom we asked that question. So there was consensus there that vaginal birth was not contraindicated. The other area that there was consensus was for women who were asymptomatic, not at risk due to close contact. And that was in terms of their partners attending or accompanying them during labor. It wasn't contraindicated for that group of women. But I think this is quite important because for the other groups of women, for example, COVID-19 positive, symptomatic, but COVID status unknown, and the asymptomatic but at risk, there was no consensus. Again, is spinal epidural analgesia contraindicated? It wasn't contraindicated. There was consensus that it wasn't contraindicated in all groups of women. Is the use of Internox during labor contraindicated? Something that you might think is a relatively simple question, but raises lots of concerns around its being a potentially aerosol generation procedure. And there was no consensus across the guideline groups. Is delayed umbilical cord clamping contraindicated? For 2 of the 4 groups for which we asked the question, it wasn't contraindicated. And for the other 4 questions, should a designated member of the neonatal team be present at birth? Is skin-to-skin contact between the mother and baby contraindicated? Is it recommended that otherwise well babies be separated from the mothers after birth? And is breastfeeding contraindicated? Each of those questions was asked across 3 groups of women, and there was no consensus in any of those 4 questions for any of those 3 groups of women. So the conclusions are fairly clear that there is large inconsistency in national guidelines from those countries at that time most affected by COVID-19. And that's of concern because it provides ambiguity for clinicians in how to treat and care for pregnant women, and for pregnant women in how they will be cared for. Does strike to a need for a greater international collaboration, peer review, quality assessed, and public funded, easy to access international guidelines. It's remarkable the work that so many international bodies put into developing COVID-19 clinical practice guidelines independently, when we suggest that doing this on a more international basis would avoid duplication and bring some better standardization of work. And there's a need for a rapid dissemination of high quality clinical practice guidelines that provide answers to important questions that clinicians and pregnant women have. And we should have a process in place for perhaps doing better next time for the current and perhaps next wave of COVID or the next pandemic. So thank you for that. Thank you, Zarko, for the introduction, and a big thanks to our international team in particular who helped us with this piece of work. Thank you.
Thank you, Declan, and I can open this presentation to the floor. I can only finish off by saying that Declan is far too nice to ask the question that I would like to ask is, how is it possible? And who are these experts? And what methodology are they using to produce these guidelines that are so disparate across the countries? And while in most instances it is justifiable because there are different healthcare systems and disease may have a different thing, but here we have a COVID which hit us all, and we all shared basically same data. We only had a couple of months and still managed to actually come up with so much inconsistency. So I'm just going to leave this question hanging, and over to you.
Yeah, thanks very much, Declan and Zarko. I think one of the obvious questions would be the timing, because we were, those of us who are working in hospital settings were hit very fast by this pandemic, well, starting in Italy, in Europe, and the amount of evidence that was out there was very small. So I think one of the difficulties we had to deal with was guidelines changing sometimes every day, sometimes even more than once a day, because there was new evidence out there. So I think if you had done this study at different time intervals, things would have changed a lot. And I know about how it was here in Portugal, and I think also in the UK with the Royal College guidelines.
Are you suggesting that there would be more or less consistency because these guidelines were reviewed, and this is why I deliberately try to kind of control for the issues that you are highlighting by having only countries with more than 10,000 cases reported?
Yeah. So, Zarko, I'm not saying that they will be more consistent now. I'm just saying they, you may, with increasing evidence, then we know.
Yeah, I get that. But people were managing. We have been managing pregnant women in mid-April. We reviewed all these guidelines within a week. So this is actually what was happening to pregnant women mid-April at the peak of the pandemic. And the reality is that these 19 countries that had more than 10,000 cases, and therefore chances to all of them be actively managing pregnant women, where there was no consistency on the issues like breastfeeding, wearing masks, and all that. That is the point.
But Adelina speaking, I think Diogo is right. I mean, in certain countries, the pandemic struck us very in a sharp way. So at that point, we really didn't have any evidence on many of these questions you are asking for in your guidelines. This is the first thing. So I agree with Diogo. And if you repeat the study within, when we have data about the registries which you are conducting, probably the consensus would be much higher. This is the first remark. The second remark is, at that point, when we were stricken by the pandemic, like in our setting in Madrid, in our hospital, really we had no room for rather healthy women. So everything was devoted to really infected, sick people, pregnant women included. So the question was, it was not possible for us to keep safe, let's say, in the safe side, and assuming rooming in mother and infant, because there was not room for that. So for this reason, many guidelines are rather ambiguous in certain items. Well, you can do that if you have facilities for. So this is very important. In the future, probably we will be prepared in a different way. And if there's a second outbreak, the management will be completely different. We will be aware about that, and probably the guidelines and the recommendations will change to a more conservative way. This is my opinion.
I just may come back in. Absolutely, there was a paucity of evidence at the time. Initial case series seemed reassuring, but most births are by cesarean, etc. However, in that case, if the evidence was so weak, wouldn't you expect much higher consistency in the guidelines to conclude that we do not have sufficient evidence to make a recommendation on how these women should be managed, for example? But that wasn't the case across many of the guidelines. For example, if that was the case, which it was the case, you would expect that a lot of the guidelines there be consensus that the recommendations were, we don't have enough evidence on which to base a recommendation here. But that wasn't the case.
But
I'm going to go to Marian and then Cristoph.
So I was just going to say, I don't know if this was happening in other countries, but certainly I was analysing UCOS data daily for the RCOG Guidelines Committee. Those data were not published. So those are not data that other countries would be working on the basis of. So if that was happening in other places, that might explain some variation.
Mm-hmm. Cristoph.
How do we then ensure, going forward, how do we learn from this experience and make sure that rather than 19 countries doing, or 20 million hospitals doing their own things, that we actually try to share this in a real time? Because the chances are that we are going to be hit with another pandemic next year. So are we going to do exactly the same thing? Everybody doing their own thing and having exactly the same inconsistency again next year?
Yeah, I think that's a very important point, Zarko. And I think at least for Europe, we have the obligation at the European Association of Perinatal Medicine to promote some international collaboration, so that, as you say, we don't all work in parallel and come up with different conclusions. So I think it's definitely something we need to think of for the future.
Diogo, I have two questions from the participants.
Elie, could I just ask, because Cristoph has asked to ask a question a long time ago. I'll get back to you in a while.
Sorry, just a very quick question, Zarko. Very good piece of work. I have to say, when looking at guidelines and when seeing what people mean, I think people do get confused with SARS-CoV-2 infection and COVID-19. And just looking at some of the slides that were presented, I wasn't entirely sure, and I'm sure you've got you know, for the full publication, you sorted this out, but it said COVID-19 positive, for instance, and then asymptomatic COVID-19. And I just perhaps point that out to you, that we've got SARS-CoV-2 and we've got COVID-19 infection, and we've got people who are COVID-19 who are SARS-CoV-2 negative, but they have presumptive diagnosis of COVID-19. I'm sorry to be mildly pedantic, but I do think this confuses people an awful lot.
Okay, fair point.
Well, actually, answering that, Cristoph, because I answered the study for Portugal, and for us it was quite clear what was SARS-CoV-2 positive and what was COVID-19. So it was, well, in the beginning maybe not so clear, but in the end I think it was very clear what it was, and we didn't have any difficulties with that problem ourselves.
Okay, thank you.
Elie.
Yes, we have two questions. How can we come to consensus when guidelines changes in every week nationally or internationally? The first question. The second question, will you do the study again and see if there is consensus now that we have more data?
So if I pick up, so the second question for us, yes, we will do it again, and look forward to sharing the results of that. The first question is, because guidelines are changing so quickly, and because the evidence base that informs the guidelines are changing so quickly, it probably drives the need for more urgency with getting some international collaboration. So we're not all duplicating the efforts across each of our individual countries, because it's so overwhelming to create these effectively living guidelines independently. And I think it is beholding on us to try and minimize the waste that that's producing, because a lot of good people are devoting a lot of time to developing guidelines that address the same questions in similar contexts.
Completely agree with you.
Yeah. Elie, I think we have to go on to the panel discussion. We have half an hour for that. Would you do the introduction?
Excuse me?
Will you do the introductions?
Yeah, you have a panel with first Marian Knight. Marian is professor of maternal and child population health. She trained initially in obstetrics and neonatology before becoming interested in epidemiology and population health. Her work focuses on using national observational studies to address clinical questions concerning severe complications of pregnancy in early life. Then we have Enrico Ferrazi, currently works at the Department of Clinical and Community Health Science in Milan. He is full professor and chairman of the department. He has published more than 400 papers in his domain of expertise, and mainly obstetrics, fetal medicine, prenatal diagnosis, screening, and fetal growth restriction. And Adelina Pellicer Martinez is professor of pediatrics and head of the neonatal unit at La Paz Hospital. She has published numerous scientific articles in her areas of research in neonatology, mainly hemodynamics and neonatal neurology and neuroimaging. Please, if you panel.
Yeah, Elie, I don't know how you want to do this, but I was thinking that we could ask, well, we gave a series of questions. Some of them were difficult and very difficult to answer because there's no evidence on which to base these answers. But I think some of the questions that Enrico has published on SARS-CoV in the north of Italy, Marian has, we've heard just now, published in the BMJ or the UCOS data, and Adelina also has a lot of experience on this area. And I was thinking that we could ask questions like, do pregnant women with COVID-19, are they at increased risk of severe disease? What, from your research, what would be your answer to that? Could I maybe start with Marian and go off to Enrico?
So in terms of those who are most at risk, the data that we have really reproduced what we were seeing in the non-pregnant population. And as per the discussion earlier from Enrico, so women who were hospitalized were more likely to be overweight or obese, more likely to be older, more likely to have comorbidities, I mean specifically diabetes and hypertension, and more likely to be from Black and minority ethnic groups. So those are very much what we're also seeing in the non-pregnant population.
Okay. Enrico. Yep. Can you unmute? There you go.
It's okay. So I fully agree with this vision projected by Marian. In fact, I think we just are leaving out one environmental factor when we consider the peak of severe clinical manifestations of COVID-19. And so if we go back and look at the environmental pollution in Lombardy in January and February, was a unique condition for nitric dioxide and carbon dioxide that never been so heavily present in the flatland of Lombardy and Veneto. And that exactly the same concentration that was recorded in Wuhan in November and December. So they're both automotive area with a lot of fossil fuel used to produce energy and to produce commuting. And what we observed that from the beginning of the lockdown in May, we were expecting an increased prevalence of severe condition coming into our hospital, and indeed it was just the opposite. As soon, together with the low environmental condition, with the low pollution in the air and the warmer climate and the warm air, the open windows and people walking in outside, the severity of cases went down dramatically, both in pregnancy and in adults. So I really think that we are leaving out this cofactor with this environmental condition that can influence the severity of the disease. And of course, as I told before, obesity and comorbidities are relevant. In our single center, we had now 61 cases, and the only two non-obese white Caucasian women were women suffering of adrenal syndrome. So they were on chronic therapy on corticosteroids. And now we have a case, just this afternoon, I switched off to talk with my colleagues up in the labor and delivery room. And she's a woman, a young woman, but she's not obese, but she suffered both of tuberculosis and syphilis in the previous couple of years. So it's, comorbidity are relevant, environmental factors are relevant in determining the severity of the disease. And of course, pregnancy in the first trimester is per se a pro-inflammatory condition. And so this virus lives on inflammations. And this, of course, makes pregnancy a risk factor for women. That's it.
Right. Adelina, I'll go back to you in a while. Perhaps mainly for the neonatal questions, but there's a question here that I think is important from the audience because there seems to be some doubt. One of our participants asked if you can explain the difference between COVID-19 and SARS-CoV-2 positive. Cristoph, can I go over to you for that?
Sorry, Diogo, I was having problems with my. Just give me that again.
If you can explain the difference between having a COVID-19 and SARS-CoV-2 positive.
Yeah, okay. So I suppose it's a slightly trite comparison, but there's HIV and there's AIDS, isn't there? So there's SARS-CoV-2 infection, which could be completely asymptomatic. There's COVID-19, which could be associated with a positive SARS-CoV-2 swab, or it could be diagnosable on the basis of other parameters, most notably a chest CT. And this, this does cause difficulties because every registry or surveillance system has to deal with people that clearly have chest infections and are very unwell and may have anosmia, but may not actually be positive on PCR or even positive on antibodies at a later stage, or people who are SARS-CoV positive and just as an incidental finding. So this is one of the major issues, I think, and I suspect many of the early reports were picking up very sick women, particularly in China, many of whom were on ITU, intensive care, and were delivered by cesarean section. There was apparently a very high rate of cesarean section in some of those early reports. And that was COVID-19, that was severe COVID-19 infection, but for every person that's got severe COVID-19 infection, there are, I'm not sure quite how many who have asymptomatic SARS-CoV, and I don't think we have those figures, particularly in pregnancy, yet.
Right. There's another question, and that I would like to put to the panel, and we have a question from Hanne Brix from Denmark related to that, and the question I think many obstetricians like to know is if there's an increased risk of obstetric complications, namely preterm birth in COVID-19 patients. And Hanne Brix writes that in Denmark, we have experienced a 90% reduction in extreme preterm deliveries from mid-March to mid-April compared to the same period in 2015-2019. Study to be published in the BMJ. Question is, does anybody else have the same experience?
Adelina speaking.
Adelina, please.
Well, I first would like to come back to the first question related to mother's disease, because we have currently confirmed 42 cases, and 20% of the pregnant women that were positive or because were symptomatic or were identified during delivery as positive had moderate to severe disease. In fact, one of them died, and they had no comorbidities at all. So maybe the environmental factors are really very important here, because otherwise it's difficult to understand. With regards to the pregnancy, the extreme prematurity, we were really amazed, because in the peak of the pandemic, I'm talking about from mid-March to the end, very recently, to 2 weeks ago, we had almost no admissions below 29 weeks. And we were making jokes about if it was the lockdown status, people at home, quiet, without movement, or something related to environmental factors, because pollution decreased dramatically in the city, in Madrid. So really, we don't know, but it happened. And we were very worried, because many countries are conducting currently a research project on infants below 28 weeks. And it has been a stop recruitment rate during this pandemic. That's amazing.
Adelina, you clearly haven't been to London, where we've been seeing far more preterm deliveries well, not far more, but certainly very, very many. And on some of Ed's data, it looks as if, and I hasten to add, this is uncleaned data, but our preterm delivery is significantly rate is in excess of what you might have expected, between 24 and 36 weeks. I have to say, I think that'll probably come down if we clean the data properly, but it certainly wouldn't equate to a reduction in preterm delivery.
But confinement was not the same around the countries. For instance, in our country, in Spain, was very strict. And that's why I think it could be a reason for that. And in other countries, in United Kingdom, as far as I have heard, was not as strict as in Spain. So maybe the behavior of the pregnant women was different, and the stressors were different.
I think we should, as you say, we should consider the rate of premature delivery according to the phase of the pandemic. at the beginning and at the peak of the pandemic, we were above 30%, then it declined, and overall now we are 21% premature delivery, which is an increase on the value we usually have in Lombardy, which is about 5% premature delivery, 5 to 7%. So it's 3 times higher. But again, it was different. Now, except for this lady who has been suffering tuberculosis and syphilis, we have been admitting in the last 3 weeks only women positive for COVID, for SARS-CoV-2, but without any symptom. Okay, so the facial areas, but no symptoms, and that's it. So we should consider the premature rate according to the phase of pandemic and not overall.
Could I go over to Marian for the UCAST data on this?
So I was just going to say that, I mean, the important thing is we've got to remember that these are not complete data. So what we're reporting on the proportion of women who have given birth. So we're talking about potentially, you know, we're saying, so for example, with the UCAST data, of the women who've given birth, there's about a 25% preterm birth rate. But 40% of the women who were infected and admitted to hospital have not yet given birth. So I think any estimates around preterm birth at the moment are likely to be overestimates of the impact across the total cohort of infected women. Nonetheless, the point that other people are making is in relation to non-COVID infected women. And I think it will be very interesting to look at sort of collateral effects. In fact, my worry has been more about poorer outcomes for women not affected by COVID because they've not been presenting to hospital early, for example, because of concerns over acquiring infection. So it's actually very interesting to hear that others are observing potentially better outcomes. I mean, I feel like Cristoph, we're not likely to be seeing dramatic decreases in preterm birth rates in the UK. I am not convinced as an epidemiologist. I'm struggling to think of how the lockdown might have impacted that. And I think we were pretty strict in our lockdown once we finally got there. And I can't comment that it was really likely to be pollution related, because obviously we've got data across the whole of the UK where pollution levels are very variable. But
is it happening mainly in large towns and cities or on the countryside? I mean, here apparently the prevalence of severe cases, not of positive cases, varies according to the area, and we were mostly affected in the automotive area, where the fossil fuel energy derived is the main energy source, and commuting is incredibly high. So I don't know. I mean, we know that the oxide nitrogen is a cause of autoimmune disease. Okay, so if an old guy is breathing for 2 months in a row very high over the minimum accepted levels of this pro-inflammatory microparticle, then when the virus hits, the two things go together. And so I think we should consider this, and probably you're right, the point of view of epidemiology should match the two things and see, because we have satellite maps of concentration of oxide dioxide and nitric dioxide, so you can tell when and where you have the highest concentration if it happens to be a cofactor for severity of the disease.
Yeah, no, it's very difficult to tease apart in the UK, where we had highest infection rates in cities, likely to be due to the number of people, and simply because it's much easier to transmit the virus. And I'm not aware that we had particularly higher severity rates in those areas, but again, it's certainly interesting, something to look at.
Elie, could you share the your experience in France, in Tours, regarding the preterm delivery?
Yeah, we didn't notice a decrease in the preterm births. We didn't notice this.
You didn't?
No.
Okay. Do you want to take over for some more neonatal questions?
I think we have some questions here and from the participants. Do you think we should advise pregnant patients to stay at home and avoid presential work, thinking in the possibility of perinatal transmission? Not if somebody can answer this question.
I'm not officially on the panel, but can I answer that?
Yeah, sure. Everyone can answer.
I don't want to steal anyone's thunder. This has been really interesting because we had an ISWOG webinar some weeks ago with colleagues from Hong Kong and Singapore, and pregnant women work on the front line there, albeit with much better PPE than in the UK we've managed to provide up until relatively recently. But you know, there isn't the same issue there, and those are countries that were affected by SARS and know the risks. So of course we've taken an ultra precautionary view. Maybe ultra precautionary is right, but I would suspect that we'll find that it has been extremely precautionary. A lot of pregnant women in the UK were really quite upset when the messaging initially was that they should stay at home and not mix or see anyone for in the third trimester. I suspect strongly that we're going to gradually move away from that position. Certainly in the UK, and I sense in Europe as well.
Okay.
So that if you consider that the third trimester of pregnancy is a pro-inflammatory condition, and why should we expose? Because the maternity leave in Italy starts from 31 weeks of gestation. And if you want, you can go and work until delivery, but by the law, you can stay home from 31 weeks of gestation. So I think that during the peak of pandemic, not now, staying at home after 31 weeks was a good idea. Now probably things should change and should have a heuristic look at what is the reality, the clinical reality. The clinical reality that we have no severe cases except for severe comorbidities associated with pregnancy. Yes. So now probably if a woman wants to go to work after 31 weeks, we can allow, and in the last guidelines we allow that. But during the peak of the pandemic, I think it was not a good idea to let people, pregnant women in the third trimester, go out to work. And
well, it's all about risk, that risk balance, isn't it? I'm simply saying that in the Far East, they did take a different approach, and I don't believe that has caused excess morbidity or mortality. I mean, I guess Marian might have some data on pregnant healthcare. There have been a small number of pregnant healthcare workers with adverse outcomes, haven't there, Marian? So you'll have a view on that.
They have, and I guess I was going to say that it's very dependent on the state of community infection rates, and I think all of these measures may change as community infection rates go down. I mean, personally, I still think for third trimester pregnant women, we should be advising them to be quite rigorous in their social distancing. I'm not saying stay at home, but I'm saying, maintain the social distancing. Think about the 2 meter space. Think about social bubbles so that you're minimizing the extent of your contacts. And I think because the women who have had the severe outcomes are in their third trimester. Going back to healthcare workers, healthcare workers were not overrepresented in the UK, in the UCOS cohort of pregnant women. But obviously we were recommending at that time that healthcare workers were taken away from face-to-face patient contact roles from 28 weeks of pregnancy. So it may be an indication that that worked.
Another comment? Yeah.
May I just ask a supplementary question on that to the panel, because I think this is a really interesting one. So if we look at Hong Kong, Singapore, South Korea, where PPE was extremely rigorously applied from a very, very early stage, and there was a very small number of healthcare workers affected overall. In fact, healthcare workers were almost certainly underrepresented. And if you look at China, the second wave of doctors in China, there was apparently a 0% infection rate with full PPE. So I suppose the question, as this pandemic gradually, fortunately, attenuates, as if there is a future one, do we feel comfortable with pregnant women with adequate PPE, which has been shown to reduce the risk of infection, working if they want to?
So for me, that has to be an individual conversation. We all have very different perceptions of risk. And I mean, you're quite right, for some women, socially isolating might be more risk for their mental health, for example, than the risk of COVID-19. But I think we have to have informed individual decisions on the basis of that. But we have to have the legislation in place that I feel that if pregnant women in the third trimester wish to be taken away from patient-facing roles, at the moment I don't think we can sufficiently say we can protect their health well enough to enforce that they have to stay in those roles. So I think having that protection in place, I wouldn't say, you know, if women chose to have an informed choice to carry on with their patient care in that kind of role, then I wouldn't have any objection to that. But I really think we have to have the protection in place to enable women to move away from patient-facing roles.
I'm sorry, I must leave the panel because they're calling me from labor and delivery, where this woman is going into a septic condition. So I have to join the group of colleagues with this COVID positive woman. I'm sorry for that.
Very good, Enrico. Yeah. All the best.
Thank you.
Yeah. Could I ask, Elie?
Yes, I have one question, one interesting question from Mexico. What is your opinion about the viral load and the presence of SARS-CoV-2 in human milk? So, to my knowledge, there is no SARS-CoV-2 found in the human milk, and we recommend the breastfeeding. I don't know what's the opinion of other neonatologists. Adelina. We have about
sorry.
Feeding and
in our guideline, it is specifically stated that if the mother is fine and wants to feed the infant, they are allowed to, always taking into account strict hygienic conditions. For sure, they should use the mask covering the nose and the mouth. I had hands cleaning very, very exhaustive. And this is our recommendation. The problem was, and we are currently conducting a specific study on this topic to see not only safety, but also the advantages in terms of immunoglobulins and other substances in breast milk that eventually could protect the infant, trophic factors and so on, microbiome and so on. The problem is, again, coming back to the facilities you have in a given setting. Because although this was stated in our guideline, the local and the national guideline, at the end, we had a problem at the beginning of the pandemic during the peak, because mothers, if they were symptomatic, they had to be in a different area of the hospital. They were moved from the maternity. They had to go to the specific COVID-19 area in a hospital, which gather all different kinds of people. And this was really difficult at the beginning to have a nice breastfeeding rate, because the mothers were not close to their infants. Now it's completely different, as the numbers of infected mothers has decreased dramatically, and they currently remain in the maternity ward. So most of them prefer to do rooming, and almost 100%, but not 100%, want to continue with the breastfeeding.
Yeah, completely agree with you. We do the same in France, but not about the viral load and the presence of the virus and human milk. To my knowledge, the virus doesn't cross the human milk.
Well, Elie, there are a couple of systematic reviews on the evidence have been published in the last 1 or 2 weeks, and they all show that it is not present in breast milk, but the number of subjects is about 20 or 30, so it's very small data. And there's a publication from the Lancet, I think from a couple of weeks ago, from a German group, that there was one case where they documented SARS-CoV-2 in human milk at about 10 days postpartum, while the while the lady was with symptoms of COVID-19. So there's one case in the literature.
Yes.
Yeah, but this is important, Diogo. I mean, because our study design is specifically, we're taking samples of a nasal swab to look at the viral load, but also at the serial breast milk samples, because maybe you can, if you just get one sample, probably you fail to demonstrate the virus there. So we need more samples in a given patient to be sure and to define the profile according to the viral load of the mother and so on. So I think we still need to answer a lot of questions regarding safety and advantages of breastfeeding in this context.
So more data are needed. Okay.
Yeah.
Elie, I'll just remind you that we are, well, it's 5:45 here, and a little bit late, so I don't know if there's a final question, but we need to wrap up relatively quick.
No, I think it's okay. Anyway, we can answer for all those people. We can answer through the mail question. We're not able to answer for them online. Okay, so thank you so very much for all the presenters. Very excellent presentations. And I would like to thank MCA for their help in organizing this webinar, and hoping to offer you other webinar topics in perinatal and neonatal medicine. So in the meantime, take care and stay safe, and thank you very much, and good night.